Well, they've been fantastic talks so far today, and this is going to try to be a fairly practical one. So for the endovascular specialist, and interesting, when you come at this from the wound side of things, a lot of times you're going to be a person who's needing to communicate with someone who actually doesn't understand the vascular anatomy, doesn't know what you just did, doesn't really care that you used an atherectomy device or you did a Safari. They do know that if you did a DVA, because you're going to have to deal with the swelling, and they know that beast, and they don't like it. But one of the things I'm just going to throw out there is on the wound side of things, there's a need for much better communication, so that they really know that they got what they wanted. Because a lot of times the reality is you're not going to do this portion of it, and that's okay. But let's talk about what you're going to be treating. So what you're going to tend to treat is our ischemic ulcers, the CTLI. And I think it's very important, and you already heard PK did a nice job of elucidating, and also our speaker who talked about the imaging studies and assessment of perfusion, is diabetic foot ulcers and diabetes and CTLI are really two different things. And they overlap, definitely. But if we do a revascularization on a patient who doesn't have diabetes, you need less quality revascularization than you probably do in the diabetic patient. We're going to touch base on that. And then also don't forget about venous leg ulcers. There's venous leg ulcers that have arterial disease, and then there's also an opportunity, if you're so inclined and interested, to intervene on the venous side of things as well. And then all other lower extremity wounds, actually, more perfusion helps. And there is some data about that. And the wound care practitioner will be a large referral source to you. And some places that's podiatrist, but other places that's going to be a general surgeon, other places that's going to be ER doc, some other places it's going to be a nurse practitioner. So I would say that there's a great opportunity for you in the future. You don't have to own the wound care, and I'll touch some base at the end of this about the generalities. And sometimes it's not going to make economic sense for you or your group to own the wound care, but to partner with people is going to be very collaborative and excellent, just like ourselves in cardiology and interventional radiology from vascular surgery. So, I think there's a couple questions that always come up, and is when you're revascularizing something right off the bat, whether you do it endo, and I've talked to endo guys about this, and I'm an endo guy at part, but I'm an open guy, so it kind of depends where you're doing it. So if you got somebody with a wet gangrene, which is rare, when you have ischemia, but you revascularize it, the timing for resection is going to be much quicker. So, if somebody refers to you that you need to revascularize the patient, and you do a great job, and you've got nice inline flow, and that night that patient spikes a fever, and because their black toe now has actually kind of reinvigorated, you're going to need to get your colleagues in who would do it. For the vascular surgeons, you might lop off the toe yourself, but also, there's the practicality of this. If you're doing the revasc in an ambulatory setting or in a cath lab that they don't, you might have an 11 blade somewhere, that's not going to get done. So collaborating and understanding what the underlying wound is, and I'll tell you, having done my training 25 years ago at the Brigham, I still remember getting called one day by Mike Conti, who was he was junior faculty at that time. He called me up and he said, "John, we got a plastic surgeon from Pittsburgh coming. Can you go find 6 diabetic foot wounds?" And I'm thinking, I got to unwrap the feet? I mean, what am I going to do here? I don't even know what I've got. But the issue here is if you have dry gangrene, you can put patients off and wait on them a little bit longer, especially if it's ischemic only and not diabetic. But you do need to debride them, and you need to think about wound care. There are patients still in this day of DVA and Safari, et cetera, that we can't revascularize. And that number continues to reduce significantly down to maybe 10% of our overall population, maybe even less. And there's the medical reasons and the anatomic reasons. There are some devices out there, the arterial assist pump, which can be used for patients who you really can't revascularize. It's basically an aortic balloon pump, and it actually was designed originally as a augmentation for patients with cardiac failure, and it turned out that didn't really work out that well. And then they kind of looked like the mask trousers for trauma, and it didn't work for that. But they did realize that when they used this for patients with heart failure, in the lower extremity, that their wounds actually healed. So they kind of created that. There's topical oxygen therapy that can affect the microcirculation at about 3 millimeters of depth, and there's enzymatic debridement. So there are options for the patients who can't be revascularized, so you don't have to worry that you're going to go immediately to amputation. Arterial assist pump looks basically like this, and as you would expect, it has, it's the reverse of a venous pump. It has a very, very rapid onset and a slow offset. And the idea here is it improves the overall perfusion to the lower extremity. And actually, oddly, although the devices, the Artisis pump's actually made in Israel and sold through a company in California. There's also Tissue Dynamics or something that's in New Jersey that makes a similar pump. But a lot of this research has actually been done by a group of vascular interventionalists in Ireland. And you can use this pump for about 3 months. And the odd portion is the TCPO2 actually improves in the foot for up to a year. And, but these are expensive, and usually you have to have a patient pay for them. The one thing to keep in mind here, and and a lot of these papers that you saw, you'll see a guy named David Armstrong, who's a very famous foot and ankle surgeon out in UCLA. And I think one thing to keep in mind is when we're talking about it, I think you gave a great talk about that. We do bypasses, we do endovascular stuff. The patient still dies, right? Because they've been neglected for a long time. We don't fix them. It's a fallacy to think, oh, we're going to fix their perfusion to their leg, they're going to live longer. No, they're already sick, right? So the thing to keep in mind that I think is very important, and it's something we have to discuss with the patients. If the patient just has a diabetic foot ulcer, they got worse outcomes than breast cancer. They also have, this is kind of a sexy, slide, but the real slide shows also lymphoma, leukemia. All of those things have a better life expectancy than having a diabetic foot ulcer, which is down here. But if they have CTLI, basically, they're right with major amputation, and the only other diseases really that are worse with mortality are lung cancer and pancreatic cancer. So our CTLI patients have a terrible, and for anyone taking a picture of this slide who likes it, there are much better pictures of this, honestly, that are more detailed that you can find from David Armstrong. This one just projects a bit better. The diabetic foot ulcer you're going to be intervening on as well. And you're going to have patients, and the ischemia matters a bit more here. I think you heard some great talks here about the lack of ability to assess the perfusion in diabetic patients. But without ischemia, the first thing you have to do, and this is what's taught to the wound care centers in general, is you need to assess the perfusion. You need to treat the hypoglycemia and the biomechanics, and you can offload aggressively. And total contact casting, which is something that probably none of you are going to want to jump into. My MAs actually can do total contact casting pretty quickly. It takes about 8 minutes, and it works very well. And it's actually level 1 data. And I'm not going to bore any of you with much data today. You've seen a lot of great data. But total contact casting is one of those things that has level 1 data to say that it improves diabetic foot ulcers. Yet 2% of patients who have a diabetic foot ulcer in the United States without a perfusion get total contact casting. So there's a total disconnect, because the thing here, and it's sort of like we're talking about with distal bypass and and endovascular, is patients don't like total contact cast. It's got great data, but I often say to a patient, it's kind of like if you said, oh, I have breast cancer, but I don't want to have surgery, and you're like, oh, okay, or I have colon cancer, but I want my colon out. Yeah, nobody likes the treatment, but the treatment for this can be pretty bad. Offloading boots work, offloading shoes don't work. These are a couple, then the rest of this talk is going to be kind of quick take-homes. Diabetic foot ulcers do require weekly debridement, and that's been shown pretty much level 1B data to show that they should be getting debrided weekly. And so if you can turn a patient with ischemia on the right here into a patient without ischemia, these are the things you need to do. Revascularize the patient as best as you can. Angiosomes probably matter more in the diabetic foot ulcer than not. You kind of saw that data before from PK and others. And once you get revascularized, you can kind of move from what's on your right to what's on your left. So total contact cast comes in a variety of systems. And like I said, actually, after you can revascularize a patient, putting these on a weekly basis should be a portion of standard of care way before you start using fancy dressings and fancy products. And the angiosome may well matter, but the interesting portion is, if you really look at the data, I think a lot of us understand the angiosome and the idea that if you have a foot or a heel ulcer, you'd like to get your PT open, et cetera. Except there are a fair number of publications, including this one on the left, which actually shows that you have the best healing with direct endovascular revascularization, then with indirect endovascular, then with direct bypass, and then with indirect bypass, which Mike Belkin from the Brigham completely showed the opposite. So again, this is one of these data things that requires. On the other hand, on the right-hand side, you see a group of patients who show that the right angiosome makes a difference in healing. So how do we, and the problem is most of these studies are actually retrospective in nature. Venous leg ulcers require diagnosis, but you also want to determine the perfusion. In general, patients with venous leg ulcers cannot get compression, so you may be asked to improve the perfusion to the patient so that they can get compression if their ankle brachial index or some other perfusion method shows that their ABPI is below 0.7, absolute pressure is below, say, 80, or their toe pressure is below 45. But also they need a venous ultrasound to evaluate their actual, their anatomy so that you can use a good vascular lab. So quickly on the left-hand side, ABPIs, and again, the data could be better, but this is what's been used in the literature for years. Between 1.2 and 9, you can compress all you want, and you want a topical moisture therapy. 0.9 to 0.7, you can probably compress as well. It's been shown by Bill Marston, who's a vascular surgeon at UNC, that you can actually compress patients with an ABPI between 0.7 and 0.5, but you need to do that in your center. You can't ask a nursing home or a nurse or somebody to do that elsewhere. Otherwise, you can tourniquet the patient and end up with malperfusion. And then less than 0.5, you definitely need to revascularize, and then you can compress. But don't forget to look at the veins too. And this is something you can provide comprehensive care on. And obviously there's level 1 data that shows that for patients with medial ankle ulcers who have venous reflux in their greater saphenous vein, they should undergo some form of ablation or surgery. That can be extrapolated to patients with lateral ankle ulcers who have short saphenous vein reflux. Concomitant perforator therapy probably will come out that it makes sense to intervene on those. And there's less data for occlusive iliac disease, but there's improving data, and I would state that probably in about 5 to 10 years there'll be level 1 data to show that you should stent occluded veins. You should do all these things, because for 20 years ago I'd give this talk and I'd say, well, there's no evidence to show that you should work on the greater saphenous vein to help with wound closure. So. But also don't ever forget the debridement of venous leg ulcers help. Most people don't debride venous leg ulcers because they hurt, but that's a portion of the algorithm, should be weekly debridement. This is a paper that was written by a couple of my fellows and a bunch of the folks over at our group about 13 years ago. And all this says is these are 27 patients with venous leg ulcers who had an APBI below 0.7, and we were treating them over the course, this is about 2 years. We treated them with a compression, and they weren't doing great. And you can see that their APBI on average was 0.56, and their wounds were about 12 centimeters, and we treated them for an average of 17 weeks. This was published in Annals of Vascular Surgery. We intervened on them. All of them were intervened on percutaneously, and we improved their APBI to 0.97. Same patient population, right? So this same patient population, 75% of them closed within 10 weeks, and 100% of them closed absolutely. So if you have a patient with marginal APBI, this is just one of the publications that supports going ahead and do that. Atypical ulcers, remember that other things other than these high volume ulcers heals better with perfusion. So you may get some patients who have atypical disease, and they're usually going to be getting something along the line of minimal debridement because they're not healing well, and they probably have some rheumatologic disorder. You need to treat that underlying cause, which is often going to be with your rheumatologist or your hematologist. You're going to use a topical antimicrobial therapy, and compression works well to help these, but they need to have good perfusion, so you're going to get asked to do this. And in closing, there are a couple generalities. The thing is, the supplies of chronic wound care are significant and may be prohibitive to you. So I would recommend, just like I wouldn't recommend someone to dabble necessarily in tibial revascularization, I think that one of the things is to know when you need help. And but if you're going to set up a center, you're going to need debridement tools, you're going to need moist wound management, you're going to need compression wraps, you're going to need offloading boots and access to total cast. There's topical antimicrobial agents and topical enzymatic agents. And all of these things are often why, quite frankly, that a lot of this care gets done in a hospital-based center or somewhere else that is going to be able to offset some of those costs and that supply cost, and also may not be what you want to do every day, and you kind of need to be doing this on a fairly frequent basis to make it worthwhile. And in general, a lot of these wounds do need to be seen weekly, either by yourself or another advanced practice person. That's been shown to be significantly beneficial to a lot of these wounds for wound healing. Weekly visits and weekly debridements often are noted to be a independent variable. The moist wound environment is important, but that can change in a very short period of time. Diabetic wounds have to be offloaded, and venous wounds have to be compressed in order to heal. And wounds with good standard of care, most of them, about 50% of them, should reduce in size by 50% at 4 weeks. If they haven't decreased in that 50%, you need to reassess that vascular supply. You need to reassess the bacterial burden. Only if they haven't, if everything is good, and that's the time that you would start to use advanced cellular tissue-based therapies. Wounds that are greater than 100 square centimeters in general, they make a good sense, especially if vascularized appropriately, to use negative pressure wound therapy. And wounds that have been greater than present for 1 year need to be biopsied. Thank you very much.